So, welcome back everybody to our Celebrating Pride podcast. This is the series which is exploring the experiences, stories and hot topics related to pride in healthcare. It was recorded with our panel of speakers earlier in 2023 and we really hope you enjoy it. In this 6th episode of the series, we will explore conditions which are at high prevalence in the LGBTQIA+ community, and we can look at how practice staff should best approach the management of these conditions.
We're going to look at the quiz here, but there's quite a lot here about sort of mental health and about sort of management of mental health and similar sort of problems in LGBT communities and patients. Noticing that there's high risk of excess alcohol drinking. There's also increased smoking behaviours, depression, anxiety, and quite some shocking figures here. And so, to me, that shows a community that is struggling accessing healthcare or has other problems that sort of contributing some of those issues, and society in general must be feeding into this. Bit of a nebulous sort of question there. How do you think we might be able to support patients within these communities better with their mental health?
I'd just start by maybe challenging something that you've just said, James.
Please do.
That it's less about in the context of this conversation, the LGBTQ+ communities being able to access mental health services. I think it's actually the flip of that, and it's about mental health services understanding the reasons why the communities may be accessing them. So, I was going to say, take a simple example. This is not a simple example at all, but it's something to sort of demonstrate it in a simplistic way. If you have a young person who comes out as gay or as trans, etc., and the family instantly turn around and say it's a phase, you'll grow out of it. No, you're not. You play football. How can you possibly be gay? All of those things that we know are said within, particularly to young LGBT people, and then that young person, at 16, 17, 18 might come to the GP. You might refer them to, a mental health service, and they go and say, so I want to talk about my sexual orientation or my gender identity, or, this is where these things have come from. I'm not sure that our current mental health systems are in a place where they have the knowledge and understanding to be able to sufficiently support those young people. So actually, because that's not there, that becomes the barrier to access, as opposed to not having equal access. It goes back to that thing about equality and equity, doesn't it? There is equal access, but actually the equity when you're in the service becomes much more challenging. So I think that for me, that's some of the sort of real challenges that we maybe see when we start looking at mental health, and you bring in things such as sexual orientation, gender identity, particularly when you then may bring things like religion or race or culture or other elements that may play into that as well. It's a massively complex area that needs specialist kind of support and input that I don't think is there in the system.
Absolutely fair challenge and extremely eloquently put. Thank you very much, Robbie.
I'll take that. Thanks, James.
No, absolutely. And I must say that my thought process wasn't quite as clear as that. But again, it really hits home to me just why conversation is important, and why actually speaking to people who've got who are the EDI leads and who are focused on this is super encouraging to help us gain some of the language and the understanding of what we're talking about. So thank you so much for that, Robbie. It's great. Andy, do you want to come in on this?
Yeah, I was going to just comment from just the perspective of a clinician who is sometimes in the room with young or not young people, discussing these issues. And I was going to talk about how I think you were saying, how do you address that? Was one of the questions that you said. And again, I think it's just not assuming that they necessarily are going to have a problem to begin with, because I've actually been with young people who, I'm being very sensitive about how I'm approaching it, and almost assuming that they're going to have all of these hang-ups, about things. And sometimes that's not what's happening. Sometimes they're there with a supportive parent who also wants to understand the young person. They're not always, so first of all, let's not make assumptions, and let's not necessarily label people, this queer LGBTQIA community as necessarily having a mental health issue. I think what I was trying to say, James, was let's not assume just because we know statistically that these are problems for this community that everybody will have a mental health issue, or that's why they're coming and that's what they need help with. People sometimes come with practical things and they want practical solutions. That's what I was struggling to say, really. So I often will ask that sounds difficult to me, what you're describing, or that sounds challenging. How are you finding it? That's how I practically start to talk to people about these things. And sometimes they say, I'm finding it okay. Quite often they're not, and there's generally always some difficulty there. But I'm just sort of curious, but try not to make assumptions, and not to lead things where I think they're going to go, because I don't know. So I'll just gently walk into it with people. I don't know if that's helpful. And sorry, I wasn't quite sure what I was saying there. I wasn't quite sure how to say. Sometimes people just don't, because it's like in our area, James, when we look at the statistics for, in Bulwell and Top Valley, there's all sorts of problems in the area that are to do with inequity. But actually, there's quite a large number of people who are just doing fine, in our area, and just want standard healthcare, and we sometimes forget that, because we can label people in our local community as being a certain type of person, has certain needs. It's not always right. So I was just giving a bit of pushback about labeling. There we go.
Yeah, absolutely right. Open mind and not making assumptions. Again, these are themes that are coming up again and again. Don't make assumptions. Ask. Be kindly inquisitive. I'm try and trademark that one. Feel free to use that elsewhere if you like. But I think just asking questions and figuring out what people's real experiences are. But I mean, I think that also I just want to acknowledge that the statistics, for whatever reason, that we've ended up in that are quite upsetting to me. Recognizing that there's an increase of stress from whatever stress and problems from whatever direction affecting community disproportionately does not sit very right for me. And trying to unpick what is the cause of that, or what we can do better to support people, I think is quite important as well. Not necessarily.
James, I would say I always do try and ask, and just fish in case there's anything there, but without making assumptions.
Oh yeah, 100%. Yeah. Brilliant. Well, did anybody else have anything they might want to add to the discussion regarding sort of mental health and supporting people's mental and emotional health in practice?
Can I ask so Robbie and Beckie, I'm curious about your roles and about what access you have to the commissioners, because obviously mental health service is something that's commissioned. People make decisions about what services they're going to commission, not directly related to gender issues, but we sometimes have trouble with things like eating disorders, and the services commissioned for bulimia and for anorexia, but not for this RFID, this restrictive eating disorder that doesn't have that body dysmorphia component, but people can still become very unwell with it, and sometimes it's difficult to get those patients seen because it's not commissioned. And I'm just wondering what influence you have on commissioning to make sure that those services are there and that we have appropriately trained counselling and other mental health services, and do you feel you've got the support? You might not. I'm sure it's a work in progress.
So from my point of view, I've come from Lincolnshire, so I'm going to be really honest and say I'm not too sure what the climate looks like in Nottinghamshire, but certainly in Lincolnshire, and I would suggest it's probably a similar dynamic, in that it's about hearing about what the issues are on the ground to then match the commissioning arrangements to that. And there's often commissioning rounds that are attached to certain services. So it's how you raise that. So for instance, for me was in a community where mental health within a student community was a particularly high interest. We've got a university that had just been placed, and there was no pre-thought about what the impact of mental health would be on a student community. So we raised that with commissioners to say, GPs are saying this. It's a common issue that the student wellbeing we're experiencing, and so we got the Mental Health Trust and commissioners around the table together to say, I think we have got an issue here. It's outside of the normal commissioning arrangements, and what do we need to do as a stopgap to get it into the commissioning rounds? And so that's been my experience. Now, it may not be exactly the same in Nottinghamshire, but I would say the principles are probably the same.
So I probably have more access, Andy, only because, as we've said, I sit directly within the ICB as opposed to sitting sort of within the system as such. So I do, I suppose, in direct answer to your question, how much influence do I have? That's challenging, because it's, as an individual, I can influence as much as I can, but do I have the influence over the services that we are going to commission, i.e. kind of right back to that almost stage one bit? No, not necessarily. It's more about that these are the services that we are, so how do we do it to the best of our ability? And that's the element that I can influence. Having said that, though, for example, within the system at the minute, myself and Beckie are working on a wider piece of work around LGBTQ inclusion across the whole of the system, and how we can improve healthcare. And that objective has come from 5 or 6 different reports, pieces of research, evidence, etc., that we've taken forward and said we need to act on this, because, as you've just said, James, the evidence is there. So actually we need to do something to make this better. And going to our commissioning colleagues and kind of having that conversation around how do we make these services better. We do have that influence within the system to be able to take that research and that evidence and that understanding to be able to guide the conversations towards a better outcome. I'm not sure if that fully answers your question, Andy, but that's probably as much as I'm going to say.
Yeah, thank you both of you. I guess the point that I hope we would all collectively make is that probably we need a bit more influence, and to get that just in people's minds when they're thinking about what services need to be commissioned, just to be aware of these needs. But conversations like this, and where this leads, help. So yeah, that's a helpful answer. Thank you both.
I think having voice at that level and being able to have those conversations at that sort of top level of healthcare organization is I think enormously beneficial. And even if it's not sort of like direct commissioning, at least having the ear of those people and having that, the representation, I think is a very good thing to go through. But Beckie, did you want to expand on that point?
It was just really saying about maximising your place-based system as well. So we're very much working around place and population health and what our local needs are. And I think it's making sure that certainly as PCNs, you get a seat at that table to be able to share some of your thoughts and ideas about what good looks like and what could be different if. And those conversations are certainly happening. And it's accepting that what might be right in one area, as you very much described, is very unique in another. And so how do we make it so it is, I suppose it goes back to that equitable and equality conversation again, but certainly there's a place at the table now where we're looking at what do we need to deliver to make our services unique for our specific population. So I suppose it's going, come to the table, come and share your thoughts with us, because we're definitely receptive to hearing that.
That's absolutely amazing to hear. And again, having PCNs being able to feed up as well, because of the diversities of areas that we have, diverse populations within diverse areas, layers upon layers of understanding.
This moves us nicely onto the topic of the next episode, which is all around the term allyship. This can be a difficult term to define, and we really hope you join us next time to learn all about it. Thank you for joining us, and we will see you at the next podcast.